A very good morning to the respected seniors and dear colleague. I welcome you all on the behalf of Neurotology Unit, Department of Neurosurgery for the CGR presentation on the evaluation in the management of juvenile nasopharyngeal angiofibroma. Juvenile nasopharyngeal angiofibroma management had underwent a paradigm shift in last decade or so. When I was a resident in otolaryngology, I have to arrange at least 3 to 4 units of blood transfusion for every patient who was operated, and the bleeding was inevitable in such a vascular tumor. With the advancement in technology and the surgical techniques and armamentarium we have in our operation theater, we are able to do surgery in most of the patient. Around 50% of the patient do not require blood transfusion. Now I will invite Dr. Nazreen to start the proceeding of CGR.
Thank you, sir. I'm here to give a brief introduction to today's topic, which is the evolution and the management of juvenile nasopharyngeal angiofibroma. So, JNA is the most common benign tumor of the nasopharynx. The German ophthalmologist and surgeon Freiherr Maximilian Joseph was the first person to describe this tumor as a fibrous polyp way back in 1847. It is a slow-growing, highly vascular tumor, and although it is benign, it is locally aggressive. And it is also associated with a high recurrence rate. So in this image, we're showing the anatomy of the nasopharynx. This is the nasopharyngeal area, and this is the lateral nasal wall, and these are the adjoining skull base areas. So this tumor is situated in the nasopharynx with involvement of the adjoining skull base areas. Moving on to some facts and statistics associated with these tumors. JNA accounts for 0.05% of all head and neck tumors. It occurs almost exclusively in males, and the average age of onset is around 15 years. In 10 to 20% of cases, there is associated intracranial extension, and it is also associated with high recurrence rates, as I mentioned before, which is ranging from 20% to 40%. Although there are a wide variety of theories which tries to explain the development of these tumors, ranging from hormonal theory to embryological theory, the most widely accepted is the embryological hypothesis or the first brachial artery hypothesis. According to this theory, during the period of embryogenesis, when there is development of the internal carotid artery and the external carotid artery, from where the internal maxillary artery arises, there is a vascular plexus which connects the ICA to the ECA, that is the internal maxillary artery. Now, during the normal course of involution, this vascular plexus undergoes complete involution, whereas in certain patients, there may be rudimentary remnants of these plexus situated especially near the sphenopalatine foramen, which is proposed to later develop into JNA. The most commonest site of origin of JNA is the sphenopalatine foramen, which is located in the lateral nasal wall, and it is formed by the articulation of the sphenoid bone and the palatine bone, as suggested by the name. Now, besides this, the other sites of origin of JNA are the pterygoid wedge, the Vidian canal, and the basisphenoid area. Moving on to the pathways of spread. Now, JNA is a tumor which is well known for its peculiar pathway of spread. As mentioned earlier, it arises in the sphenopalatine foramen. So in this diagram, this is anterior extension, this is superior, this is left side, and this is the right side. So from the sphenopalatine foramen, it can extend medially to involve the nasopharynx. Now from the nasopharynx, it can have a midline spread anteriorly to involve the nasal cavity or the ethmoids, or from the nasopharynx, it can go superiorly to involve the sphenoid sinus. Besides this, it can also have a lateral spread when from the sphenopalatine foramen, it goes laterally to involve the pterygopalatine fossa, from where it extends further laterally to involve the infratemporal fossa. The other mode of spread is the paramedian spread, wherein from the pterygopalatine fossa, it goes via the superior orbital fissure to involve the cavernous sinus and further extends to the middle cranial fossa. The other paramedian spread is one when it extends anteriorly from the pterygopalatine fossa to involve the maxillary sinus, or via the infraorbital fissure, it extends into the orbit. Coming to the pathology, on gross appearance, these tumors are firm, well circumscribed, lobulated, and pinkish to whitish in appearance. On section, they are highly fibrous and non-encapsulated. Coming to microscopy, the myofibroblast is the cell of origin. There is Dept fibrous tissue with abundant endothelium-lined vascular spaces. Now, what is most peculiar about these tumors is that the blood vessels lack a complete muscular layer, which explains the torrential and profuse bleeding associated with these tumors. Now, molecular analysis is an area where a lot of research is being done in recent times. This not only helps in explaining the etiology of these tumors, but it also helps the formulation of targeted therapy against these tumors. Although there are a lot of molecular markers, the most important ones are the androgen receptors, which are seen in around 75% of these tumors, and the vascular endothelial growth factor, which is seen in 80%. Besides this, the laminin alpha-1 is of importance because it supports the vascular theory of JNA. Now, how do we come to a diagnosis of JNA? This is based on the history, the clinical examination, endoscopy findings, and also radiology. History-wise, the patient is usually a young adolescent male who presents with history of nasal bleeding and nasal obstruction. On clinical examination and nasal endoscopy, there is usually a nasopharyngeal mass. And the point to note here is that JNA is a tumor in which preoperative biopsy is contraindicated. Coming to radiology, the investigation of choice is a contrast-enhanced computer tomography of nose and paranasal sinus. And in addition to this, we may need a contrast-enhanced MRI or a digital subtraction angiography on a case-to-case basis. Coming to the symptoms, as mentioned earlier, the most common presenting symptoms are nasal bleeding and nasal block. And depending on the stage of disease, the child may also have a cheek swelling, palatal bulge, proptosis, or sometimes hearing loss due to the obstruction of the eustachian tube by these tumors and development of this medium. On anterior rhinoscopy, what we usually see are retained mucopurulin secretions, and sometimes, depending on the anterior extent of these tumors, we may be able to see a pinkish or whitish mass. On nasal endoscopy, this is the left nasal cavity. Again, what we see are retained mucopurulin secretions. On suctioning these secretions, we will be able to see the pinkish mass denoted by the star, which is located between the nasal septum and the inferior and middle turbinate. Now, radiology-wise, as mentioned earlier, the investigation of choice is a contrast-enhanced CT scan of nose and paranasal sinus. Now, this gives information regarding the bony anatomy of the paranasal sinus, which may be distorted by the tumor. It also helps in the delineation of the extent of disease and also shows the skull base involvement in the form of the erosion of the various skull base foramina. Now, an MRI may be warranted in cases where an intracranial or orbital extension is suspected, and we may also need a digital subtraction angiography to assess the vascularity and the feeders supplying the tumor, to help in embolization of these tumors, and post-embolization to also assess the residual vascularity. In advanced cases, this also helps in surgical planning by deciding the surgical approach. Now, these are various CT images of JNA and the various extensions. In the first one, the tumor is seen involving the nasopharynx with widening of the sphenopalatine foramen. In the second one, there is a contrast-enhancing tumor involving the nasopharynx with widening of the sphenopalatine foramen and extension to the pterygopalatine fossa. The point to note is the pterygopalatine fossa is the area which is situated behind the maxilla, and thus the maxilla actually acts as a gateway when we decide to tackle these tumors. On the third image, tumor further extending laterally involve the infratemporal fossa, and in the fourth one, the tumor is situated in the nasopharynx with erosion of the basis sphenoid and extension into the sphenoid sinus. Now, this is how JNA appears on MRI. On T1 sequence, it's a well-defined iso-intense mass with multiple flow voids. On T1 with contrast, it will be seen as an avidly contrast-enhancing mass. And on T2 is usually a hetero-intense mass with multiple flow voids. These are various MRI images showing the different modes of intracranial extension seen in JNA. In the first one, the tumor is extending to the pituitary fossa from the sphenoid sinus. In the second one, the tumor is seen involving the cavernous sinus via the superior orbital fissure. In the third one, the tumor is involving the anterior cranial fossa via the ethmoids. And in the fourth one, the tumor is seen involving the middle cranial fossa from the infratemporal fossa. Digital angiography is a modality which is both diagnostic as well as therapeutic. It helps in identifying the main feeding vessel and the vascularity of the tumor. The commonest feeding vessel is the internal maxillary artery. In large tumors, there may be contributions from the ascending pharyngeal artery, the contralateral external carotid artery branches, and sometimes there may be feeders from the internal carotid artery also, which usually are not embolized, and therefore the tumor will have some residual vascularity from these ICA feeders. Coming to embolization, it is usually done transarterially with gel form or PVA particles. It is done 24 to 48 hours before taking the patient for surgery. And the advantages of doing embolization is that it significantly reduces intraoperative blood loss, helps in better visualization of the tumor, and also thus reduces the total operative time. And these are two images showing the pre-embolization picture showing the feeders and the tumor blush. And post-embolization, as you can see, there is complete absence of tumor blush. Now, the modified FISH classification system is the most widely accepted and widely followed classification system. As per this, stage 1 and 2 are early stages confined to nose and paranasal sinus. Stage 3 and stage 4 are late stages, which involve the orbit, infratemporal fossa, and the intracranial cavity. Now, we in SGPGI have further modified this classification based on our publication in 2016, wherein in stages 3A and 3B, we add the suffix AE and AI, which denote the vascular supply from ECA or ICA. I now invite my colleague, Dr. Manjul, to throw some light on the management of these tumors.
Thank you, Dr. Sri, and good morning to everyone. I would like to go ahead with the mainstay of management of juvenile nasopharyngeal angiofibroma, which is the surgical excision of the tumor. So, a successful surgical excision of JNA requires close coordination between the various departments. The role of Department of Anesthesia cannot be overstated, as they play the most important role from the pre-operative phase up to the post-operative phase. We require a coordinated team effort with neurosurgery department in cases with intracranial extension, and from the pre-operative diagnosis to the diagnostic subtraction angiography and embolization, radiology and intervention radiology plays a vital role. The Department of Radiotherapy comes into play in the post-operative period, or in cases in which removal of the tumor might not be possible because involvement of vital areas. As it's a vascular tumor, multiple transfusions may be required in any of the phase the patient presents to us, including the preoperative phase, and close coordination with transfusion medicine is extremely important in making the surgery safe for the patient. So let's see what are the preoperative anesthesia considerations. So we try to optimize the patient with a hemoglobin of around 12 milligram per deciliter, anticipating blood loss. And allowable blood loss is very important, especially in adolescents, as the estimated blood volume is limited with around 70 milligram per kilogram. It's also necessary to discuss preoperatively the embolization results and the residual vascularity. So based on these discussions, we take the patient into the OT. So the primary consideration inside the OT is that we share an airway with the anesthesia team, and the chances of patient aspirating because of the bleed are also high. So this needs to be taken care of. Along with the usual intraoperative parameters which are monitored, monitoring of temperature is also important, especially as patients are mostly juvenile or adolescents. So based on the expected blood loss, invasive lines are also planned. It's also very essential to maintain an intraoperative hemoglobin levels between 8 to 10 milligram per deciliter so as to maintain adequate tissue oxygenation. As it's a vascular tumor and blood loss is expected, hypotensive anesthesia is preferred. So let's move on to the techniques and approaches of surgical management of JNA. As mentioned earlier, that this tumor lies in and around the maxilla, and the maxillary sinus acts as a gateway to exposure of the tumor. So almost all of our techniques and approaches, they differ on the basis of how we expose the maxillary sinus and what are the walls of the maxillary sinus which we remove, so as to get a good exposure of the tumor and control over the vascularity. So the surgical approach has undergone a paradigm shift in the last decade. So initially, the approaches used to be extensively open approaches, which led to increased morbidity to the patient. They also used to leave a scar, which was cosmetically acceptable, but used to stay for a lifetime. So these approaches included the transpalatal approach, lateral rhinotomy approach, the maxillary swing approaches, and in cases with extensive intracranial involvement, we had to go ahead with craniotomy and the infratemporal fossa approaches. So after the 2010, in the last decade, after the endoscopes have become more into the play, we could go ahead with surgeries which are less invasive and are scarless. So we have completely endoscopic approaches. We have an open approach by the name of midfacial degloving approach. And in most of the cases, we even combine these two approaches. The craniotomies have also become less invasive with trailered craniotomies, which are being used nowadays. So the current surgical practice is to go ahead with an endoscopic endonasal approach in cases, in almost all the cases in which it's feasible. If because of the extent of the tumor, we have to go with an open approach, we go ahead with scarless open approach by the way of mid-facial degloving. These are done especially in cases with post-embolization residual vascularity from internal carotid artery. So like I mentioned earlier, the combination of these two approaches, putting an endoscope into use even in an open approach, makes tumor removal from critical areas safe, and also makes drilling of the skull base and basis sphenoid area where the tumor is supposed to arise from more efficient, just thus making chances of recurrence lesser. So how do we decide on what approach are we supposed to take? So this is based on the important factors: anatomical extension of the tumor, the residual blood supply of the tumor post-embolization, and the surgical experience of the team involved in this primary management. So we from SGPGI has published a protocol for the management of the approach to be taken for the management of JNA. So in all the stage 1 and stage 2 tumors with involvement of sinuses and the nasal cavity, we go ahead with endoscopic, completely endonasal approach. So in mid-sized tumors, that is stage 3 tumors with involvement of the pterygopalatine fossa and infratemporal fossa, we can go ahead with open approach or endoscopic approach. This is based on the experience of the team. In stage 4 approach, in stage 4 tumors, we are forced to go ahead with an open approach. In revision cases, the decision is based on the location, vascular supply, and experience. So let's go on to some of our representative cases. So I'll initially mention all the extensively open approach we used to do initially. So the first one of these approaches was the lateral rhinotomy and Weber-Ferguson approach, whereby we end up with a cosmetically acceptable but permanent scar on the face. The advantage of this approach is that it gives good exposure of the tumor and the area we are concerned about. But like I mentioned, as it's visible in this image, the patient ends up with a facial scar. So because of this consideration, we have moved on to an open approach named as transpalatal approach. This in this, the incision stays inside the oral cavity, and we approach the tumor inferiorly. Because this approach could give us only inferior access to the tumor, this can be combined with a sublayer exposure of the maxilla, thereby giving access to the tumor both superiorly and inferiorly. But this was still a morbid or a morbid approach, as the patient could not take orally for at least a week or two after the surgery. Then we moved on to a lesser invasive approach, which is in vogue even now, known as the facial degloving approach. So this approach, actually, we give the incision intraorally over the buccal mucosa, and this is very efficient in exposing the whole of the skull base up to the palate, thus giving complete control over the tumor and its vascularity. So like seen in this picture, this approach also gives us good access so that two surgeons can work together to suction and also to introduce an endoscope, which makes this approach very safe and efficient. So let's see video of how we go ahead the mid-facial degloving approach. So like I told, we give a mucosal incision 0.5 to 1 centimeter above the gingivobuccal sulcus. So we leave this 0.5 centimeter so that post-operative suturing is easy. After that, we expose the bilateral anterior wall of the maxilla by raising a musculo-periosteal flap. Then to increase the access, we give nasal incisions. The initial incisions are the intercartilaginous incisions which we give bilaterally, which is followed by an incision anteriorly in front of the septum, which is known as a transfixion incision. Then these two, the openings are communicated together, and using a gauze piece, we expose the complete anterior part of the maxilla. After this, we can go ahead with removing this part so as to expose the tumor. So let's see how these tumors are managed stage-wise with representative images. In stage 1 tumors, like you can see here, the tumor is treated to the nasal cavity. There is no involvement of the surrounding sinuses. This can be removed through an completely endoscopic approach. Like we can see here, complete exposure of the tumor is possible. This is a small tumor, and without leaving any residual, it can be safely removed. So this is a stage 2 tumor where there is an involvement of the sphenoid sinus. It has eroded and gotten into the sinus. This can also be exposed completely using an endoscopic approach. And like we can see here, the whole tumor has been removed safely. So now let's go on to stage 3A tumors. These have got vascularity from like this is our modification of the staging, and like mentioned here, this has got vascularity from external carotid artery. And after DSA and embolization, all these tumors, the vascularity can be controlled. So even in these cases, we can go ahead with completely endoscopic approaches. So these are the multiple stages of the surgery, which I'll show video after this. Just to give an introduction, so we go ahead exposing the maxilla by what is known as a modified Dunger's approach, and then we remove the anterior and the medial wall of the maxilla. The first important structure which comes in our way is a nasolacrimal duct, which we can see here, which has been cut. So then we drill the posterior part of the maxillary wall, and we remove the tumor using what is known as a coblation wand. This uses plasma to cut the tissue, and it suctions at the same time and helps us in providing bloodless field. We also drill the skull base so as to avoid residual or recurrences, so as to remove the cellness. And this is done using a high-speed skull base burr. So in the previous case, we had seen a right-sided tumor. Here we have a same stage, but a left-sided tumor. I'd like to show how I do the surgery in these cases. So here, like I told, using a modified Dunger's approach, we expose the maxilla, and then we remove the anterior and the medial wall of the maxilla. So after the walls are removed, the first important structure which comes in our way is the nasolacrimal duct, which we can see here. It's very important that we cut this nasolacrimal duct using a sharp instrument so that epiphoria does not happen. After that, we expose the posterior part of the sinus and also the maxillary sinus and the pterygopalatine fossa. The bone here is completely removed. So after this, we get a complete view of the tumor, and we start delineating the tumor slowly from all the attachments. So like I told, it also has to be removed from an nasopharyngeal attachment. So this is done using a coblation device. After the complete removal of the attachments, we deliver the tumor. This can be done either intraorally or through the nose based on the extent of the tumor and the size of the tumor. So once the tumor is to remove cells and to prevent recurrence, we drill the skull base at the areas of attachments and origin. So we at SGPJ practice a particular step after removing the tumor, which we call as the matching of the specimen. So once the tumor, we put extreme care in making sure that the tumor is not left behind and is removed in toto and not in piecemeal. So after the tumor is removed, we match it with with the radiology, with the extent, and we see that every part where we can see the tumor going in the radiology is present in a specimen. We feel that this is very important in making sure inadvertently we are not leaving anything inside. So this is a stage 3A tumor, but with residual vascularity from ICA. In these cases, we can see that the patient does not have any scar, but we have removed it using the open approach, which I have mentioned before, and the mid-facial degloving approach. So even in stage 3B with ICA residual supply, this can be completely removed using mid-facial degloving approach. We still have to go ahead with extensive open approaches in stage 4 cases with extensive involvement of the skull base and the intracranial part. So these tumors are usually done removed using stage procedures. The first procedure would be removing the nasal and the skull base part, which in this case has been done by a procedure known as maxillary swing approach, whereby we anteriorly place the whole of the maxilla, remove the tumor, then we put it back using screws and plate. So let's see how the intracranial part is removed. This is usually done as a stage procedure and as a second stage. So in most of these cases, we need a craniotomy. We need to retract the temporal lobe. We have to expose the skull base, and then the tumor is completely discarded off slowly from attachments, making sure that we are not getting into the tumor and we are also not leaving anything behind. And as the tumor is being removed from cavernous sinus area, the little bit of bleed is expected, which can be controlled efficiently. So like we can see here, we are making sure that we are not getting into the tumor or removing the tumor piecemeal. So let's move on to post-operative follow-up of these patients. So all these patients are followed up after the surgery for first 6 months with monthly nasal endoscopy. So as the patient needs cleaning of the nasal cavity. After 6 months, we go ahead with a post-operative MRI to check for residual or recurrence. If the post-op MRI at 6 months is not suggestive of any residual or recurrence, the patient is then put on yearly follow-up with nasal endoscopy. And if any clinical suspicion of tumor is there, we go ahead with a CMR. If first post-op MRI is suggestive of residual, then we get an MRI repeated at 6 months again, after 6 months. So if there is no interval increase in size of the tumor, we keep the patient under follow-up. As the patient grows, there are chances of involution of the tumor. But if there is any increase in size of the tumor, we have to go ahead, and with clinical symptoms, we have to go ahead with either surgery or IMRT based on the location of the tumor. Now, I would like to invite Dr. Kalyan to go ahead with our experience of managing these tumors.
Thank you, Dr. Manju. Now I will talk about our experience with this tumor. So this is basically a surgical audit of duration 10 years between June 2013 to June 2023. The number of surgeries were 142. The actual number of patients were 130, in which 12 patients had recurrence. So it sums up to 142 surgeries. So if you spread the same data here, we can see that up to 2016, we are having less number of cases, which were around like less than 10 per year. But from 2017, we had a surge in the cases, more than 15 per year, sparing 2020, where the COVID pandemic happened. So as my colleague said, JNA is one tumor which is very common in the adolescent age group between 11 to 20 years. Even in our series, we had around 85% of our patients in that subgroup, followed by third, first, and fourth decade. So the mean age is 16.5 years with 7.2 standard deviation, and the median is 16 years. JNA is unique because of its exclusive male predisposition. Even in our study, all 130 patients were male. So we have followed modified risk classification. In this chart, we can see that majority of our cases were in stage 2 and stage 3, followed by stage 3B and stage 1, with very less number of cases in stage 4A and 4B, where there will be frank diagnosis. Around 51% of our patients underwent DSA with embolization. In this graph, if we see, the green box shows the total number of cases in each stages, with the line graph showing the number of patients underwent embolization in the each subset of the patients, with the box above with percentage showing the percentage of patients underwent embolization in each stages. So it clearly shows that all our 4A and 4B tumors and majority of our stage 3A and 3B tumors were embolized, with very less number of cases being embolized in stage 1 and 2. That too, in our initial phase, before 2015, where we have embolized stage 1 and 2 tumors because we were embolizing all the tumors during that time. Surgical approaches primarily has been used as endoscopic assisted midfacial approach, endoscopic approach, and external approaches. So we can see that endoscopic assisted midfacial approach and the endoscopic approaches, which were minimally invasive, were way far more than of the external approaches in the last decade. The significance is that the hospital stay. So in endoscopic assisted midfacial approach, the patient stays with us for 5 to 6 days, whereas in endoscopic approaches, the patient stays with us for 3 to 4 days. Whereas in external approaches, the patient stays with us for 7 to 10 days. So the hospital stay indirectly correlates with the cost burden on the patient. So as we all know, JNA is very vascular tumor, and the age of presentation being pediatric, the blood transfusion plays a major role. So around 41 patients in our 142 patients underwent transfusion. So the chart clearly shows that up to 3A, the requirement of blood transfusion is less, like around less than 25%, whereas in stage 3B, it's increasing up to 50%, and in stage 4A and 4B, almost all the patients were transfused. Complications, we had one ICA feeder injury, we had one vestibular stenosis, which has been managed with local flap, one sixth nerve palsy, which improved over time, and 2 patients where we have converted from endoscopic approaches to endoscopic assisted approach because of increased bleeding. In our series, we had no mortality. Coming on to follow-up. So from minimum of 3 months follow-up to the maximum of 10 years follow-up, the mean follow-up time was 5.6 years, in which we had 12 recurrences. So majority of the recurrences presented within 2 years with a mean of 2.1 year. And in this chart, we can clearly see that the stage 2 and 3 tumors recurred very rarely, with stage 4A and 4B tumors recurred majority of the time. So rather than recurrences, the stage 4B tumors can be called as residue because we are forced to leave back the disease due to either increased bleeding or its adjacent to the vascular structures. So in these 12 patients, 6 of them underwent redo surgery and doing fine. But the rest of the 6 patients required radiotherapy. So here comes the data. So we want to emphasize on the age group on this data. So we can see that 5 out of 6 patients were less than 15 years, where the tumor will be very aggressive in the early teens, which might require radiotherapy also. With the minimum follow-up of 2 years to maximum follow-up 9 years, we had stable disease with no complication till date. So this CT shows us the involvement of the left cavernous sinus and the encasement of the ICA by the disease, which could not be removed completely with the surgical management. So this patient has been referred for radiotherapy. So these are some of the indications for radiotherapy. And what radiotherapy does is this thing. So post 6 years radiotherapy span of one patient with a stable disease with no complication. So a study from Delhi shows the long-term treatment outcome from juvenile nasopharyngeal angiofibromas with radiotherapy, which is favorable with the radiotherapy for these tumors. So this is one of the recent advances in the angiofibroma field. 68 gallium prostate-specific membrane antigen PET CT scan. This plays a vital role whenever there is a confusion between the recurrences and the post of inflammation or fibrosis. This scan comes in play. So this could be able to differentiate between these two, whether it is a recurrence or it's a post of inflammation. Coming to the cost analysis. So surgery without DSA costs us around 25,000 to 40,000. The price range in between depends on either we are using the powered device like ablation or the skull-based drills. So surgery with DSA costs us around 60,000 to 1 lakh. Though DSA is costly, it plays a vital role in decreasing the transfusions and decreasing the recurrence rate in our patients. So over to Dr. Amit Kesari for concluding this session.
Thank you, Dr. Kalyan. Coming over to discussion and conclusion. This is the study which is published from our institute in 2006, published by the previous consultant, Professor Isha Tyagi sir, in the department. And this study consists of 95 cases. In this study, the main approach which was used was also a non-facial scar approach, transpalatal and the sublabial approach, and majority of the tumors were stage 2 and 3. So these tumors, the recurrence rate was close to 18%, And that was there in the open approaches. This was the pre-endoscopic era. Another is that our institute was one of the first to adopt the DSA for the embolization of these tumors. And most of the tumors were extensive tumors here. And we can see the blood loss was around 1000 ml on an average to 1400 ml on an average when there is a supply from ICA. Up to 2 liters of the bleeding has also been reported in this our article from our institute. Coming to the modern understanding of our skull base, especially the tumor arise in and around the Vidian canal and pterygoid area. Now it is no more called nasopharyngeal because it is the nasopharyngeal extension. It usually arises in this area. And also working with the neurosurgery team all the time for the skull base surgery, we know that where the tumor arises and how does it goes into the anterior cranial fossa and the middle cranial fossa. We have shifted to the minimal invasive endoscopic approach. Have we become better? No. The resolution of the CT MRI become better. We have now 3D planar DSA systems where we can see all the vessels and they can tell us better that what the residual supply, and we can kind of map the tumor according to the blood supply. Anesthesia has allowed us more hypotensive anesthesia, and also the blood transfusion, which was earlier target was 10, now 8 also is done. And we have a very good neuroanesthetist and other anesthesia team here. We have better energy device. Coagulation was the game changer because it can have suction, coagulation, and dissection tool at the same time. And then bipolars and high-speed drills. 4K high-definition endoscopy system allowed better visualization of the tumor. An advent of endoscopic skull-based surgery with a steep learning curve, which we have crossed with the neurosurgical team. The first study we have published is the 2016. We have published around 15 cases for stage 3 tumor specifically and modified the staging system. And we use endoscope for the first time in the open approaches like the mid-phase degloving. Here this is a little busy slide, but we can see here the blood loss, intraoperative blood loss is approx 300 ml, maximum 600 ml, and more blood loss was there when there was a blood supply from ICA, which is expected because it is usually not embolized. Then coming to again, we analyzed our data after this for the around 42 patients, that what is the role of embolization in JNA. And then according to our classification, we devised a technique which is called a step ladder approach for juvenile angiofibroma, and it is well accepted and well validated now worldwide. So again, when we see the DSA data here of all the patients, majority of the patients when stage 3, what was important that in stage 1, very blood supply from one of the, not even the maxillary artery, the sphenopalatine artery, which we can control easily. So in now onwards, we are not embolizing stage 1 and stage 2 tumor because we can control it endoscopically during the surgery, and also the blood transfusion is not required anymore in stage 1 and stage 2 tumor, although we reserve the blood because complication can happen anytime. In stage 3 and 4 tumors, if there is a ipsilateral and contralateral supply, this is where it is important to have blood transfusion in hand. And also we identified some of the new vessels which was not reported is the facial artery, which is supplying the tumor, which cannot be controlled by any technique, but only by DSA. So this is the CI protocol, which already has been talked about. Here we are, for a smaller tumor, we are planning endoscopic approach. And we have reached this stage that with our experience that we are now almost into the 3B approach. Ravi is here. We both are now to this approach. We are trying to do some of the tumors, but up to the B by with external supply by the this endoscopic approach. Coming to the world literature, there is a meta-analysis that how the things have changed. So this is a 2023 articles published, and we can see that there is significantly lower recurrence with endoscopic, because only majorly because of the optical advantage and the areas we can reach with the endoscope was not possible with the headlight and the pre-endoscopic era. Only with the microscope it was possible. And again, coming with the blood loss, we can see that endoscopic approaches has average blood loss of 500 ml, which is lesser in our series. And the open approaches, endoscope-assisted open approaches has also less. But when we come to the open approaches, the blood is more. This is a meta-analysis from the world. Yes, ma'am. So lastly, we are working on the molecular characterization of nasopharyngeal angiofibroma. And we are looking at VEGF and beta-catenin. Also, we have translated this endoscopic surgery to the other tumors of the pharyngeal sinus, especially benign and malignant tumors we published in recent times. And we use specifically this technique of skull-based involvement in mucormycosis, and we also published that data. And this is some of the presentation was done in national and international and award won by our residents. To conclude, the GNM management has evolved in last decade. Endoscope or endoscope-assisted mid-phase degloving technique are now a standard of care. And tumor up to stage 3 are better suited for endoscopic and rest by endoscope-assisted open approaches. Endoscopic surgery has a learning curve, but can be overcome. Multidisciplinary team approach, I cannot thank the team of anesthesia, radiology, transfusion medicine, nuclear medicine, and radiotherapy, tumor board with radiotherapy. And this tumor management is not possible without a multidisciplinary team approach. I thank you, my team, especially Rabi is here and the resident. And I leave this with message that if we can remove the tumor without a facial scar, it is very good for the patient because the scars remains the patient with the lifetime. And we can get similar result with endoscopic surgery nowadays. Thank you.